Welcome to Cardiac Delusions. Let's see our quote today. For any heart failure symptoms, give diuretics. Is that true or false? We have a 49-year-old male patient presented to the OPD by dyspnea on mild exertion for 1 month. He had anterior STEMI 2 years ago, for which he had primary PCI to LAD, but his serial echoes showed estimated ejection fraction of 30% with akinetic LAD territory, suggesting that there is residual LV dysfunction since the anterior STEMI. So he was diagnosed as heart failure with reduced ejection fraction, as his ejection fraction here is below 40%. On examination, his blood pressure was 110/70 and heart rate was 80 beats per minute and regular. It was in sinus rhythm as proved by the ECG. He can lie flat, so he is not orthopnic, and there is no lower limb edema and no fine basal crackles. When we checked his medication, he is taking aspirin 75 mg once per day, atorvastatin 40 mg once per day, bisoprolol 5 mg once per day, sacubitril valsartan 100 mg twice per day, furosemide 40 mg once per day, and eplerenone 50 mg once per day. The first option that was suggested by many colleagues is to increase his diuretic dose to reduce any congestion, and so it would help to improve the patient's symptoms. But there was another opinion that this patient may need to optimize rate control at first. So what would be the appropriate therapeutic option in this clinical situation? Let's revise at first the definition of heart failure in the 2021 ESC Guidelines. Heart failure, as we know, is not a single pathological diagnosis. It is a clinical syndrome consisting of cardinal symptoms plus minus signs of decompensated heart failure due to structural or functional abnormality of the heart that may result in elevated intracardiac pressure and or inadequate cardiac output at rest or during exercise. So this is a definition of heart failure, not just a diagnosis by echo, it is a clinical syndrome. We have 3 subtypes of heart failure. All of them share the same symptoms and signs of decompensated heart failure like dyspnea, orthopnea, paroxysmal nocturnal dyspnea, plus bilateral lower limb edema, congested neck veins. And so the definition or the differentiation between each one of them depend on the ejection fraction. In the first type, ejection fraction is below or equal 40%, so we call it heart failure with reduced ejection fraction. In the second type, it is between 41 to 49, so we call it mid-range ejection fraction. And in the third type, it is above or equal 50%, and there is objective evidence of structural or functional abnormality that may be consistent with LV diastolic dysfunction or increased LV filling pressure, so we call it heart failure with preserved ejection fraction. So back to our patient who has heart failure with reduced ejection fraction. What can cause dyspnea for this patient? It may be due to volume overload caused by saltwater retention, and the mechanism responsible for this is the renin-angiotensin-aldosterone system activation, and it may be due to increased heart rate, which results in shortening of the diastolic time, so the diastolic filling is shortened, resulting in pulmonary venous congestion, and the mechanism responsible for this is sympathetic activation, and we call both these pathways the neurohormonal stimulation. Volume overload can manifest itself as generalized edema, which usually starts as bilateral lower limb edema below knee, and it can extend to above knee up to the anterior abdominal wall. It can result in orthopnea, which is a classic symptom for decompensated heart failure and volume overload, fine basal crackles, which can be auscultated on the chest, and congested neck veins. Whereas the increased heart rate, we can detect that the patient is having heart failure symptoms, but his resting heart rate is above 70 beats per minute, and sometimes it may be caused by irregular rate like in atrial fibrillation or frequent ectopics, which also impairs the diastolic filling time. In the first type, he would benefit from diuretics, whereas in the second type, he would benefit from rate controlling medication. That's why it is important to determine whether the patient is having which one of them, or he's having both of them, in order to decide what would be the appropriate step for his medication adjustments. So let's suggest that this patient is having volume overload. In this case, I can advise the patient more on salt restriction to be less than 3 grams per day, increase the dose of loop diuretics, or sometimes we can change to a more potent type like from furosemide to torsemide. We can add or increase the dose of mineralocorticoid receptor antagonists like spironolactone or eplerenone, which antagonize the secondary hyperaldosteronism. And sometimes we can add thiazide or thiazide-like diuretic in order to produce sequential nephronal blockade, in which we are giving the patient 3 types of diuretic: loop, thiazide, and mineralocorticoid receptor antagonists, resulting in significant diuresis to antagonize the volume overload. What if the patient is having increased heart rate? So he would benefit from rate control. So I would advise the patient on caffeine reduction. I would increase the dose of beta blocker in order to reach the target heart rate to become below 70, down to 60 beats per minute. I can add ivabradine if target heart rate is not reached on the maximally tolerated dose of beta blocker. I can add digoxin in some cases if still not controlled, or in atrial fibrillation, in which the second choice for rate control is not ivabradine, it is digoxin. And I can consider in some cases like atrial fibrillation to schedule the patient for cardioversion or sometimes ablation if I suggest that the atrial fibrillation is responsible for the clinical deterioration of the patient, and I can consider ablation in case of high burden of monomorphic BVCs. But what would happen if we increase the diuretic dose for this patient who is just having increased heart rate without volume overloads? The patient here would not feel any symptomatic improvement, and he is still complaining due to the shortening of the diastolic time. And on the other hand, the intense diuretic therapy in an avolemic patient may precipitate hazardous effect like dehydration with increased blood viscosity and so risk of thrombosis. It can increase the risk of hypotension up to hypovolemic shock, especially if the patient is not having adequate fluid intake, and it may result in acute kidney injury due to ischemic tubular necrosis. So here, of course, the increased diuretic therapy is not the appropriate solution. That's why in 2021 guidelines, all these medications like ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, SGLOT2 inhibitors, and sacubitril valsartan are recommended as class 1 for mortality benefits, whereas diuretics like loop diuretics here are recommended as class 1 in patients with heart failure with reduced ejection fraction, just for symptomatic benefit to alleviate heart failure symptoms, improve exercise capacity, and reduce heart failure hospitalization. The same recommendation also is for heart failure with mid-range ejection fraction, and with heart failure with preserved ejection fraction, it has the same indication. So diuretics are indicated in congested patients who have symptoms or signs of volume overload in order to produce symptomatic benefit. So regarding our patient who is aovolemic and does not have any signs of volume overload, we should not increase the diuretic dose, and we should optimize rate control to reach the target heart rate. So we can increase the dose of bisoprolol up to 10 mg once per day, guided by blood pressure. And if the patient is not tolerating this dose, we can add ivabradine 5 mg twice per day up to 7.5 mg twice per day. So regarding this malpractice that any patient with heart failure symptoms give him diuretics or increase his diuretics dose, this is completely wrong, and we need to assess the cause of the heart failure symptoms. If this patient is having symptoms or signs of fluid overload, so the patient needs to start or intensify his diuretic therapy in order to reduce the volume overload. But if the patient is avolemic but his heart rate is above the target, here the patient needs to intensify his rate control therapy, which helps to prolong the diastolic filling time. Thank you very much for watching this video, and wait next week for the next cardiac delusion.